Kathryn Grayling, so I'm Director of People, Culture and OD at the ICB, and I've taken over, if you remember, from Suzanne in helping to facilitate this community group around discharge and safe transfers of care. So I'm just going to open some slides so that we can get started. They're always slow to load when you're staring at them, aren't they? A few more joining now. Okay, so welcome to those of you that have just joined. We'll get started because we've got quite a bit to get through. But what we thought we would do during this session is just have a look through what's happened since our last session so that we can keep track of our achievements and our impact. I'm just going to take you through a brief update on Boost, which is the new brand for our learning and improvement community that you're part of. And then we felt that at a quarter of the way through, we had an opportunity to kind of take stock, reflect on the collaborative so far. And we're going to use a tool called a retro board. So I know Ashley's been in touch with some of you, but we're going to also walk you through that today. And that piece of kit is just going to provide us a platform to make sure that whatever topics are decided for us to work on are decided by the community. So in the spirit of the reason we were set up and not decided outside of the community. And we're going to be exploring a couple of questions. So what next and what do we want to work on going forward and what key themes are arising for you as our members of this collaborative? And we're going to do a group activity around the themes and future work. And we have got a couple of things planned in, but as always, we can take the scope where you think it would add greatest value. So at our last collaborative meeting, we had Kerry Evans along, who spoke to us about the National NHS Care and Volunteer Responder Scheme. And she was challenging us to think differently about increasing capacity to support discharge. We've had some success with that. We've had a few contacts to report that have either met or are meeting before Christmas. So Samantha Hood's looking to engage the volunteer responder service for the Pathway zero discharge patients in Newcastle. Heather, I'm sorry if I say this wrong, Candelant from Volunteer Matters runs a home from hospital service in Newcastle, and they're looking to see how the volunteer responder service can help with their service, perhaps for those that are referred or don't meet the criteria but still need help. And there was a meeting yesterday between Stephanie Roberts and Judith Curry from Queen Elizabeth Hospital in Gateshead, looking to see how the scheme could help their work in terms of patient and discharge experience. Presenting to the AHP invited, facilitated by Julie Ridden and Ruth Malanga and Dr. Maria Avanti Argo Quinn. So that's an opportunity then to have the volunteer responder service go along to that meeting and really talk about how it links into that work as well. So some real impact just from that first conversation. So thank you to those of you that are involved, and we'll keep sharing that experience as we move forward and have more to discuss. I can't see the chat, Ashley, as we're going through this, so just do shout up if there's anything. Oh, I've got it up now, it's fine. So the next session that I'm going to talk to you about briefly is Boost. And I know many of you, because this is part of the Boost work, the Discharge Collaborative now. So some of you will have been seeing this branding come up, and you'll have seen our yellow backgrounds that you were so complimentary about this morning. But Boost builds on the work that we've run in our region that have been developed out of the work of CLIC, the Cumbria Learning and Improvement Collaborative, and the Northeast Transformation Service work, and has drawn in kind of industry experts and academics from across the region as well to really think about what a healthy improvement community would be like. So the key areas of focus for Boost are now crystallised for our region, and these are building an effective and mature learning and improvement community, of which you are one of our primary and initial examples. That we will grow leaders everywhere that have the skills and agency to lead improvement across the system. We'll continually ground innovation and improvement in the real work that matters to people. And again, this is where we're representing it in this group. We're learning together, shoulder to shoulder with people with lived experience, those leading work, and those that can enable improvements. We're committed to sharing our story and seek to involve all people in our improvement work. And we're developing the skills, capability, and capacity for learning and change and improvement for all. So that's wherever you're working within the system, we have a support offer that helps you to develop that capability around quality improvement. We're connecting parts of our system to each other and to other systems and internationally where we can learn from practice from abroad. And we're using data and evidence to drive our learning approach. We promote innovation and we're spreading good ideas, and we want to really encourage that experimentation, sharing and learning about what does and doesn't work. So that intelligent failure piece is really important to us in sharing our learning in a psychologically safe way. So I told you that we'd engage with academics, and a lot of the theory that's sitting behind the learning and improvement community within Boost is around the human learning system. So this is around it describes the complexity of working in a system-based way with our people and our citizens at the centre of what we do. But we know that from a culture perspective, we also need to work on, how we build trust together, how we do data-driven improvement, how we work collaboratively and lead collaboratively. And you can see that represented here. So our improvement work and our intention around this and a healthy system is around that ecosystem for change. And here we've drawn on the Bill Bonnier model to always and intentionally have around decision making the voice of intent, which is those who are capable of driving change through authority. The voice of design, so those people who are creative, who help us to think objectively about what we're doing and how we get to information in the right way. The voice of capability, so those that are engaged in delivering the change and the work, and the voice of experience, so our people with lived experience that can talk to us about what's really needed and what will make a difference for them. And we want to remain really committed to that. So in a second, I'm just going to play a video that just reminds us, and I know it won't be new to all of you, but it's the, I think it's Mrs. Anderson, I've forgotten the lady's name, but it's the video, it's on YouTube, and it really talks to us about the journey of a patient user, and I think is always a helpful refresher to us as we're working on this. So I'm just going to play that for a few minutes and then we'll move forward. I know that'll be a familiar story, and everyone in this room will be able to resonate with what we saw there, but I think a really powerful reminder of what we're trying to do together. And so I just want to return us to the purpose that you all agreed you wanted to have at the start of this journey. And you wanted to improve the safety, experience, and outcomes of patients being discharged from hospital and transferring their care. And you stated that you'd do this by learning together to share your understanding of what works and what doesn't work, connecting and building relationships, sharing knowledge and supporting each other, in understanding how we can adapt and adopt good practice, and testing out ideas that can lead to positive difference, and using the collective knowledge we have within the group to experience to solve problems together. So that's what you set out for us at the start of this journey. So what have you covered so far as a group, or what have we covered so far? A directory of members has been created. We now have a WhatsApp group running, and we'd love it if you'd utilise that more, and get some real engagement within that group. It's your group, it's as informal as you like, it's just a way to communicate with each other, and Ashley's popped the link in the chat for anyone who's not already a member. Kathryn and Rachel, system coordinators at South Tyneside and Sunderland, have been to talk to you and share their session. Kerry Evans at the Volunteer Responder Service has been along to talk to you, and Kelly Coulter has been to talk about personalised health budgets for discharge. So quite a lot really since getting going. So the improvement work that we've captured so far as a result of this group is the streamlining of processes and agreed practices across health and social care, and having discharge facilitators, social workers and therapists working on a case management model for discharge. And that's happened. So Carol Martin's the lead for that one, if anybody does still want to know more about that. Optica, which stands for the Optimised Patient Tracking and Intelligent Choices application, is being implemented across the ICB Acute Trust to reduce the average length of stay for patients and minimise avoidable delays, ensuring that patients are discharged to the right place of care and at the right time. And this has also been looked at in terms of Optica from a community and mental health perspective, and this has been piloted within 2 North East North Cumbria ICB providers, and we will share all these slides. And we're integrating our dementia advisors with Admiral nurses in Northumbria Health and Care NHS Trust to help to ensure that people affected by dementia are supported in hospital and on discharge by the service and the service of the Alzheimer's Society. So there's links there as well. So if anybody's still interested in wanting to know more and where those are up to, please do get in touch with the people named in this section. So the speakers we've got lined up for the future sessions. So in January, we've invited Paul Carruthers along, and he's going to be talking to us about the transfer of care hub managers, but North Cumbria Integrated Care and NHSFT. These things are not easy to read, by the way. I feel like I'm doing a tongue twister over and over. And he's going to be talking about co-production and delivery of the discharge to assess pathway, supporting safer transfers of care and ensuring promoting a home first approach. And then in February, we've got Zoe Pierce from the Discharge and Flow team at Barnsley Hospital to talk to us about their work on improving patient journey and experience from admission to discharge. So I've done far too much talking now. So really wanted to pass over to yourselves and think about collectively what next for the collaborative. What would you like to work on? Are there any key themes you want us to draw out? Because I think there's that within the community we've got people that are seeing things from a range of perspectives, and we want the future focus to be owned and governed and decided by yourselves. So this is where we're going to use the retro board. And I know some of you might not have been using this before, so I'm going to ask Ashley to come off mute in a minute and just talk us through what we need to do next, and then I'll talk us through the board once it's loaded up.
Okay then guys, so I've just popped the link to the retro board in the chat, and I'm hoping if technology stays on my side, it should literally be as simple as following that link through. And then you should be greeted with a screen that looks like this. So hopefully everybody is okay in following that link. Sam's put a thumb up. Lovely. Thanks, Sam. Brilliant. Please shout if you're having any problems at all, and I will try my best to support, but it should, as I say, be as simple as that.
So if you're having issues, just drop Ashley a message in the chat and she'll guide you on. And I'm just going to walk us through how we're going to use this. So you can see a number of columns on here. And what we're going to do is just work on this column to start with. So the to discuss column, which is the one on, gosh, it's the orange one. And all I'm going to ask you to do, firewall blocking a link. Ashley, I'll let you work on that in the background while I just walk people through this. Hopefully, get people on. So to discuss, all we need you to do is add a new card, and this is where you can put in any themes or any topics that you'd like us to focus on over the next few months. Once people start adding in the cards, you'll see them line up one above each other, and you can start to vote on them then. So if we just give you a few minutes, so 10 minutes, just to start adding in cards. It's just this to discuss column, which is the orange one. And then we'll see what themes are coming out, and then we'll do a voting exercise, which will allow us to prioritize the ones that are the most popular themes. So that's it. Brilliant. We've got somebody's in and doing it. So so we've got our first one on there, and just keep adding as many as you like. There's no limit to these. And then once you start to see them be populated, if you agree with that theme, give it a thumbs up. You can add a further comment into it by just clicking on the little orange box itself if you want to add anything further to it. But if you vote on them as well, then it gives us a chance to look at which ones are the most popular ones. And I'm going to stop talking. I promise I won't sing a Christmas song to you or anything. Okay, so we've got a number of themes arriving on screen now. So some people are starting to vote on them. The more votes that go onto any particular theme, the higher it will rise up the list, and that will just help us to decide what you'd like to prioritize. If no one really votes, we're going to have a lot to discuss over the next few months. So do try and cast your votes on those. You do that with the little thumbs up sign sitting underneath the themes. So just there where Ashley's showing. So anyone late joining, this is a retro board, and all we're doing is adding new cards. There was a link posted in the chat to click on, and it should bring up this board. And under the to discuss theme, which is the orange one, which you can see being populated, people are just adding new cards on themes that we might want to discuss at future sessions. Should be reordering itself, Ashley. I don't know if we just need to refresh it. It all goes wrong. Okay, or maybe not. Might be. Is there a ranking button?
I'm gonna have a little look. Let's see. That's focus mode.
We're so on the technology today.
No, that changes the colour of it.
Not to worry. I can do a quick count. It's not a problem.
Yeah, might need to do that.
That's fine.
Oh, it's put it like that now instead.
Wow. This is
That might be better.
dizzying.
Is that worse?
Who knows? Who knows? Let's we'll persevere. So if you're seeing a theme up there that you agree with, if we just give that one last minute just to cast your votes, and those of you that are later on joining, if there was anything you wanted to add, please do. Okay. And it's not to say we won't get through all of them, because what we'll do in future meetings is we'll pop this up at the start of every meeting, so we will get more familiar with these boards, and we'll revisit any themes that we've not covered before to see whether there's, you know, a slight repositioning of them that would mean that we could bring it to a later session, or any that are kind of left on towards the end we might be able to work through at a later date. Oh, there's a
Ashley,
sort button.
Just at the top, there's a sort button next to the search button. Second one in next to the search button.
There is. Up a bit, up a bit. There we go.
Thank you very much. I don't quite
Love
know.
it. Thanks, Karen.
Now. It's a bit different, but
It is. I wonder if can we go back to the other view that we had before, Ashley?
you would
Or...
ask me that.
Yeah, no.
Let's see, how do I get it?
Full of the tricky questions today. How do you go back? Who knows?
No, not that one. Oh, the joys of technology.
The trusty back arrow.
There we go.
The trusty back arrow.
Right, and let me try and sort it again.
Sort it.
Sort
Perfect.
into
Thank
votes.
you.
There we go.
See, we will get better at this. Okay, so we can see that the winner of today's poll is the role of the third sector. So what I'll do, can you click and drag that across into the discussing part, please, Ashley? That's great. And drug changes on discharge and virtual wards step up and down. That's the top three as far as I can see. So if we move those into there. Great. Okay, so you might want to just scribble these down, because in a minute we are going to go into breakout rooms just to dig into these a little bit deeper. So we will post them in the chat in your rooms as well, but just so you can get up and running, it might be just worth noting them down. So what we're going to do is go into breakout rooms, and we are going to think about those top three subjects that you voted for today, and just ask you to share if you're aware of any good practice that you know of already that the community would benefit from hearing about, or any improvement work that you know is already taking place, whether that's outputted or in progress. And just think about who would we want to be involved if we were going to host those top three sessions. Who would we want to be involving with the community, and what's the next step? So so ideally we'll end this breakout time with our initial step forward, an idea of who we'd like to come and work with us on these themes, and hopefully some ideas around where there is some green shoots of good practice that we might be able to draw on as a collective. So Ashley's going to pop us into some breakout rooms now. And how long will we have, Ashley?
Oh, well, we're running ahead of schedule, Kathryn. So
we're running ahead.
As long as we need, to be honest.
Okay, so what should we try first?
Should we do half an hour?
Yeah, so that's a good chunk of time to get into conversations. Please don't drop out of the call while we're transferring you, because it does result in the odd 1 or 2 people being left on their own, and that's never nice. So yeah, a good time to get into those conversations. We'll post these questions as well, and then when we come back together, we'll do some sharing of what's happened within your groups, and we'll agree some next steps for this collaborative. So as if by magic, Ashley.
Yeah, the rooms are opening now.
Okay, you should have the link and you should start disappearing. So 30 minutes, if somebody can scribe for each group, that'd be great for feeding back. Welcome back, everyone. I'm hoping you had enough time there to get into some detailed conversation. It's always a risk, isn't it, when you go to breakouts that people think, oh, of that long list of emails they need to send and everything else. But yeah, hoping you got into good conversation, and just wondered if we could take some feedback from each of the groups around kind of what you discussed, if you did highlight any potential areas that are undertaking improvement work, or anybody that you think we should involve in this conversation as we move forward, and then we can move that into an action column on our retro board. So I don't know if anybody would be kind enough to volunteer to go first. And silence. Sam, thank you.
That's all right. I don't mind going first. So we talked about I think it was it the third sector to start with, and we had Carol on in our group, and she's from Tyne Housing, and we were talking about how, you know, whether or not we could be an option to provide short-term housing for somebody that, you know, potentially can't go back to their own home. They're ready to be discharged, but can't go back home because of environmental issues or cleaning or, you know, whatever it might be. And, you know, they just need somewhere. Sorry, my dog's messing about with Bloody Bone. Yeah, they just need somewhere really that they could be discharged into safely, short term, whilst that work was completed, and then they could go back home. So Carol felt that that was definitely an option that their housing could look at, and because they're, you know, they're drug and alcohol sort of experts. That's what they sort of focus in particularly, and also, you know, we talked about homelessness and people that are homeless and maybe you know, drug users. We could look at, you know, how we actually discharge them back and link them into Carol's service, rather than, because, you know, they'll just normally, you know, you treat them, don't you, and then, you know, you discharge them back onto the streets. But actually, how, you know, if we maybe linked them in with Carol's service, or, you know, for North Cumbria, somebody like-minded, you know, we could maybe prevent another admission, you know, if we could tackle some of that drug and alcohol, or sort their homelessness out, or, you know, that because they provide lots of other services in terms of employability coaches and all that sort of stuff. So I think it's, you know, it's that having that knowledge, I think, isn't it, of organisations out there that we can discharge people to safely, you know, and maybe prevent future admissions. So we talked about that. So, you know, definitely a role for the third sector, and just having some knowledge really of what's out there, and starting to have some conversations, you know, with some of the housing associations, possibly in the north, in North Cumbria, because obviously it's Tyne Housing that provide that particular service. So we thought about that. So that was a really, have I missed anything off, Carol?
So Sam, were you thinking as a future? Go on, sorry, Carol, go on, you go first.
Sorry, I think I just sort of gave an example, because although it's a relatively small housing association, the breadth of the services would meet this particular need. And we're already working with NHS England on the Transform and Care programme. So we're looking at a second property for somebody with learning difficulties and needs. So it's more or less the same tree, just a different branch, if you like. And I know obviously we're quite small and we only cover the northeast region, but there'll be similar organisations that could give you that holistic approach. It's just something, and if you think about in terms of the cost benefit analysis and what it's costing now and what a commission service would cost, I would imagine it would be really quality service at quite low cost as well.
So
sounded like a pitch there, didn't it?
so that was what we were thinking in terms of sort of third sector, as a possible option.
Paul, were you wanting to come in on that point?
I don't want to obviously that group off if there's any more to come, but I suppose it was just kind of following on from the discussions that we had in our group, but I don't want to cut that.
Well, shall we stick with this theme then,
Yeah.
and just see if groups want to come in with their input around third sector, and then we'll work through the other two. Does that make sense?
Yeah.
So, Paul, then?
Yeah, absolutely. So following on from the theme of kind of third sector, so it was just kind of whether it's classed as best practice, I'm not sure, but it's something that we've kind of been doing at North Cumbria now for some time, and it really has worked, and we're starting to see some of the data sets come through. So often or not, when the third sector kind of topic came available, we used to try and kind of look at using some of that available capacity, but it was always done on like goodwill, and it was trying to find volunteers to support, and it maybe wasn't as fast as the hospital required it to be, and then the relationships would break down. So what we did about 18 months ago is using money out of the Better Care Fund and some kind of grants, is that we actually commissioned third sector service supports to do some core offerings, and we didn't actually prescribe, we didn't say here's some money and you will do this. We gave them some money and said these are our problems, what can you do? And they then came back with the answer, and that was really helpful. So we've now got a core set of services which we now know are not required to support domiciliary care, so that's not what they offer, but they support all of the things that we know impact discharge. So key safes, we know on average it takes 4 days to get a key safe set up. They have a bunch of temporary key safes that they'll whiz out and click to the person's house, and then they'll send the handyman out to fix the actual key safe afterwards. It doesn't delay discharge, but they've got that network of supporting it. They do deep cleans, so they'll go out and do the deep clean. If the deep clean is found to be much more kind of complicated, or that it requires kind of environmental health, they will do the onward referral on our behalf, and they will manage that, so and then feed back to us when it's been kind of completed and chase it up. They will take people's if someone's downstairs living because they can't get upstairs, they will bring everything down. They'll support white goods. They do some benefit support, so making sure people have got the right benefits so that we can get them onto things like Meals on Wheels, so that we can make sure people are well fed. And they have a bit of slush fund within there which they can use to their discretion to put the extra bits and pieces in. So all of that basically is something that it's one number, we ring that service, we know that they'll do it in a really quick turnaround time, and not only do they do that, they then can support that patient in that time to then put onward referrals to other third sectors, so things like loneliness, keeping moving. So it prevents the early readmission, which we often see after discharge when you've had someone in hospital for quite some time, lots of people around them, they go home and they're all, no one else around other than maybe a few care calls a day, and they're kind of quick in and out. And it's just that holistic lower level need. What we're aiming to get to eventually, but obviously we're a lot far off here, is a single point of access for third sector services. So it doesn't matter if you're a GP, a social worker, a nurse on a ward, that you would have one number to ring to who is people that are specialist in all the third sector services are offering, and do that referral for you. Because often or not, we found third sector services are on small budgets, so they get like a 3-month contract. By the time someone knows about that service, it's stopped. And having every clinician and every person in a system to understand who is doing what with what criteria, it just doesn't work. So having that kind of single point of access who can take the issue or take the problem and then align that with the right service, we feel would both help for emission avoidance, so when things are starting to fall down in a person's home, but also for those that are needing things, if you're a GP in a GP surgery, if you're, so that's our main kind of, that's our blue sky thinking, I suppose, and that's where we're trying to get to on that. But I was saying to some of the people, I'm more than happy to share the service spec that we've got with our third sector support. and it wasn't expensive in the grand scheme of things.
So, Paul, how do you see that working then? Is that like a director of services or like a
Yeah.
navigator?
Yeah, a bit of both.
bit
So
of both.
yeah. So rather than it being like I make a referral into a third sector service and they come back and go, I really appreciate you ringing back, so we can't do that. And then it gets passed back to the referrer, who's often a busy clinician, and then they have to then go and find the other person. And in the end, they just go, well, you know, I've sod this, I'm not going to do this. So it's about being able to refer into a service, a bit like your adult social care single point of access, and they will then do that other stuff. And if they can't get it from there, they'll go to there, or they'll maybe find a voluntary service. But it's not, it's that one way of referral. It's, you know, it keeps going forward rather than being passed back.
Okay, got a couple of hands up. So Jenny first and then Carol.
Yeah, thanks, Paul. I think that sounds really interesting, your service spec. I think it would be fantastic if you could share that. And because I sit on the Ageing Well regional group as well. And for me, there's something about these environments where we can share this and get this out as wide as possible, because all of those things that you've said there that are a limitation to discharge, every single hospital, every single, you know, whether that's an acute trust or a community hospital or even a mental health trust, will come across all of those, and you clearly have got some solutions to that. So let's share it, you know, and if you've done that through Better Care Fund as well, I think, you know, that sounds like it's a really good blueprint for others. So if we can share that, and I'm more than happy to support getting that out and across through the networks that I kind of support. The bit around the single point of access, I think, again, is one that many places have been grappling with for a long time. I was involved with some work in Darlington, you know, probably 10 years ago, trying to do exactly that, trying to get a single point of access. And it's an absolute bloody nightmare. But it's one that we should still continue to try to do, because you're right. I think it will unlock lots of different things. And I just wondered whether you'd had any conversations with VON, the Voluntary Organisations Northeast, because I know they're also trying to do some of this, and that's where some of this stuff at scale might actually help. But also then recognising that actually you probably can't do this particular bit at scale because of all the nuances of what happens at place. But if there can be some strategic direction that's given by VON and the ICB, actually that will then give places some of the oomph and the ability to then say, this is the right thing to do, so let's invest in this locally. So again, I would link and do it that way around, because otherwise we'll all try and scrabble to do it and it will continue to get kicked into the too difficult box. But this is the option of these collaboratives, is to really look at those too difficult boxes and try to come up with some of those solutions.
That's great. Thanks, Jenny. Carol.
Yeah, I was just going to say what Jenny was in terms of VON, because they're already involved in terms of they're the single point of contact, aren't they, for all of the voice in terms of the structures. So, you know, they've got the complex needs group, they've got the mental health group and all of that. So if that would probably be a good place to start in terms of our area anyway. The second thing was, I just want to say, Paul's hit the nail on the head in terms of the third sector, because obviously the nature of the public sector is so different, whereas a third sector organisation can just be so flexible in terms of delivery and so cost effective. And if you think about it, the only issue that would be is the one point of contact, because the sector in its very nature is very, very competitive.
Seen lots of nods of agreement there. So I guess from an action point of view on this one, then there's the question of the too difficult box that has sat around that single point of access, and how we might approach that in terms of engaging with VON to help us to kind of do some framing of the issue and look at the art of the possible, but then probably looking together in our next conversation about the direction we work on that from. So whether that's around the ICB and setting that strategic direction, and then, you know, having a bespoke model for places, but something that we'd want to look at supporting or exploring in a further level of detail. Is that fair? Okay, so we'll move that, unless anyone has anything else to add on the third sector theme. No. Okay, Sam, can I come back to you for the next thing that you discussed then?
Yeah, and the next thing that we talked about was virtual wards, and we had quite a long conversation about virtual wards, and I think we felt that there needed to be some probably education and information around the sort of whole system, really, in terms of what a virtual ward is, what it does, so that, you know, we could improve clinicians' confidence around using them. I think we need to get to a point where we're all using virtual ward as step up and step down, because, you know, we need to, it obviously support discharge, but it also would support admission avoidance. So, you know, we felt there was a big piece of work to do around comms.
Okay. Jenny.
Sorry, it's me again, and apologies because I came late to this, so I wasn't here at the beginning. But for those of you that don't know me, I'm Jen Steele, and I'm actually one of the Ageing Well clinical leads for North East and North Cumbria, and I'm one of the clinical leads that's also supporting virtual wards. So Sam, I think your point is really well made. The challenge we've got is that virtual wards means different things to different people in different areas. And the language around virtual wards is really confusing. It's confusing for health professionals. It's even more confusing for patients. So I'm not surprised that that's come up, and I think it's really important. And I'm happy to take that back to the virtual ward group as an ask. I suppose what my ask back is, where do you want that information to be? Because we've got representatives on that virtual ward, this sort of the steering group that happens for the region. But what I'm hearing is that that information isn't getting disseminated appropriately from that meeting, and I'm really keen to help support that. So, but I need you to tell me where we need to come and infiltrate so that we can help in that dialogue and that understanding.
That's great. Thanks, Jenny. I think Paul's coming back in on that. So over to you, Paul.
Yeah, I think that would be really helpful because, like I say, so you must hit the nail on the head there, and it was about, you know, means different things to different people, because we've got like the virtual ward, which I was trying to explain in our group, is for us it's still people that would technically meet the criteria to reside, but they're going elsewhere to have their ongoing treatment. And for me as a transfer care home manager, I kind of support when someone's discharge ready. But there's other things going on, which is like the virtual ward, but it's about virtual home care and virtual care homes. And it's, are those things connected in, and if not, do they need to be? And so we can learn from any pitfalls, and if they are, that I would be really keen to kind of get involved with that. I know our local authority are starting to pick up some of that, but they're like really early days. So it's like responder services to when someone's got a problem, rather than just putting care in place to do time and motion just in case. So then we can save more care in the pot for the next person.
Okay, so it sounds like there's a lot to distinguish between those three models then, and that's what we need to be looking at. Anne-Marie.
I was just going to say I work in primary care and in a PCN role, and it's just kind of knowing when we have to take over the care as well and things like that. So we're still trying to kind of understand virtual wards and where we fit in, and when we need to change the medicines or who's responsible for what. So it would be really useful to kind of link in, and we still don't really understand which virtual wards are starting to kind of take place and in our areas really. So any information and links would be really useful for us too.
So I wonder if an action from this is that I could look to share with this group, probably via you, Kathryn, the virtual ward leads that come to the virtual ward steering group, the regional steering group. And if I share that with you, because you're absolutely right, Anne-Marie, this has got to be done at place, because what a virtual ward means in, and forgive me because I don't know where anyone's from, but what a virtual ward means in Sunderland and South Tyneside may well be very different to what it means in Gateshead and in Hartlepool. So you need to have those conversations at place to understand how the pieces of the jigsaw puzzle fit together, because some people call virtual wards, it's really hospital at home, and those people absolutely would otherwise have been in hospital. For others, as Paul suggested, it's a bit of a handhold. So once you get home, it's just easing you back into things, and both are right on some cases, but actually if you read the definitions that's been set out in the NHS England documents around virtual wards, there is a quite clear definition, but the reality operationally is that it's really variable for lots of different reasons, and many of them are not digitally enabled, even though again that says so in the spec, and I'm probably speaking completely out of turn, but that's the reality, and I deal with reality rather than rhetoric. And the reality is that, you know, digital is there and it's starting to come through, but it's not, and rightly so, not the driver, because the driver's got to be better patient outcome.
So we've got something about definitions, and thank you for that, Jenny. We'll definitely take advantage of that. There's something about definitions and whether we'd want to have a standardized definition. It sounds like there already is one, but it's been translated differently in different places, and whether that's something that we could agree to work on together and standardize across the ICS footprint, or you're shaking your head, so no?
I am, just because I think you will struggle, so which is why I think you need to do it at place, because at place that's where people will know what it works like in that local area, and you'll get to know your local dialogue and the language that's used in those areas. It's a bit like urgent community response and crisis response and first responders and all of that stuff, you know, it's very locally dialect dependent. So, and trying to get a single definition across the board, you'll spend hours doing it and not get nowhere, because people will still like to call it hospital at home or early supported discharge or whatever other terminology they use. I'm happy to be, you know, if people think that that's worthwhile, you know, but that's just my personal opinion.
And I guess you know, whilst absolutely hear that, and I think that's really valid. Is there though, is there an opportunity, because what are we going to compare different things in different places because we're interchanging names, and does that reinforce that variation then? And Patrick's wanting to come in, so over to you, Patrick.
Yeah, I just wanted to say, as a patient, the different terminologies in the health service are just totally confusing, and I think are a big problem. So anything you can do to sort that out, I would advise you to do. For example, nobody in the public knows anything about ours rules as far as I'm aware.
Thanks, Patrick, and a massively important point. And I think that is the challenge to us, isn't it? Because if we do accept that variation in title across our different places, then there's always that higher potential for confusion, both within staff or from our patients and service users. But then there's a balance, isn't there? As you said, Jenny, there's that local ownership and the fact that people have set off down a trajectory. So it does sound like we've kind of unearthed something that does sit in that really difficult box and is worthy of further exploration to see what could we do, what's right to be done, or what should we leave alone and allow to develop within that. So if we take the information that you've got for us, Jenny, and then maybe work with yourself, if you're happy to do that, about how we can frame that within this group for a further session. Did anybody else have anything on virtual wards before we move on? Because I think we just went quite organic then with the conversation, but I want to make sure we've not missed anything. Okay, great. So we'll take that away and think about it. And we'll make a proposal with Jenny about how we look at that in a future session and share that with you in case we're going way off mark, and you can have a chance to steer that before we have the conversation as well. Okay, so there was one last theme then, I believe, which was drug changes on discharge. So does anybody want to kick us off here? And I think we've got take home and tuck in as a subsection on this one. I think that's the second time I've heard that referenced, and I've not heard of it before. So,
yeah, I've just sent actually Kathryn and you Ashley some information on the take home and tuck in service, and this is provided by an organisation called Ambulance, that provided a full service in North Cumbria for a period of time. Unfortunately, we've not been able to continue that full service due to funding, but this is another service that they provide, and I know they provide it in other trusts in the Northwest, and it's really well thought of. And this is a service for patients that are in ED that home but aren't able to for whatever reason. So, you know, it's trying to stop that admission. So it's collection from hospital. It's safe and comfortable journey home, assistance home and into desired locations such as bed or chair, welfare check, providing them with refreshments where available and appropriate, leaving the property safely with access routes clear and door secured, with the option for crews to return to the property to check on the patient's well-being if required. So, for example, if somebody's care package isn't starting till later on that day, you know, the next day, they could go in and make sure that they were all right and provide some support. So that's basically what it is, but it's an organisation that have you know, ambulances that are exactly the same as our ambulances that we see with the NHS, and you know, they have fully trained crews, and you know, they do also have the ability to provide a full service as well. So you know, they're well kitted out, so they're a really good organisation to you know, work with. We, as I say, the only reason why we stopped our full service was because, you know, we didn't have the continuing funding, sadly, but it is definitely something that we would look at in the future. So it was that's that service. So I'll ask Kathryn and Ashley to send that round to people to give you a bit more information. And also we talked about you know, people that were being discharged, but maybe for whatever reason their TTOs were delayed, and whether or not we could you know, was there a service that we could provide that delivered their medication to their home, save them waiting in hospital.
Brilliant. Thank you, Sam. I think unfortunately we've lost Kathryn. I assume she's had some technical difficulties, but that's great, Sam. And yeah, I've got that information, so I'll send it out on the back of today's session with the slides as well. Has anybody got anything else to add to the topic of drug changes on discharge? I'm very conscious of the time. We've got 2 minutes left. Angela.
Yeah, we did touch on a little bit in the group about some work. Anna's joined the call now about work that's done on medicines reconciliation and discharge, and there's a similar hub that works on that in Darlington as well. Just trying to ensure that any drug changes that have been made are intentional and are not accidental. So I didn't know whether, Anna, you would be happy to come and discuss the work that you've done in Sunderland, or I know you weren't on the call at the time. quickly messaged her.
No, I got your message. I'd be happy to come to a later meeting and kind of give our project overview and things like that. That would be fine, yeah, and probably got some useful information for everyone, really.
Fantastic, Anne-Marie.
Just let me know when and where.
Brilliant. Thank you very much. That's great. Fab. And then Jenny.
There's some work in the ICB as well that Anne-Marie may be aware of, and I can't remember the two chaps that have been leading on it, but around that direct information from hospital pharmacies into community pharmacies so they can support with this discharge and transfer of meds, etc. So again, it seems sensible to link all of that up, because I think we're all grappling with the same thing. But from the conversation I had briefly with them a few weeks ago, there is a solution. We just need to sign up to it, which again, there'll be a money cost and all of that. Yeah. But actually, there is a solution.
Brilliant. Lovely. Thanks, Jenny.
Was that great. Michael Maguire, Jenny? Was it Michael Maguire and Andre Young?
Yeah. Yes. Thank you.
Michael Maguire. Hang on, I'm jotting those names down. And Andrea Young. Brilliant. Thank you.
Yeah.
Fantastic. That's great. Right, I'm conscious of time. I think Kathryn's literally just come back. I'll let Kathryn quickly wrap up. I've taken some notes, Kathryn.
Brilliant. And apologies for that. My neighbours just knocked my power and Wi-Fi out with their building work. So it's that dreaded moment, isn't it? Brilliant. is the conversation complete then, Ashley? So I'm just going to bring that last slide
I
up
think
then.
so, yeah, we're at 3 o'clock as well, so
Brilliant. Okay. Well, hang on, I'm all to cock now, Ashley. So
that's all right.
you.
Oh, I think I've lost her again anyway. Nope, she's gone again. Okay then, guys. Well, thank you so much for attending today. The next session is going to be on the 17th of January. I'm trying to remember this now off the top of my head. 11:30 till 1 o'clock. So we hope to see you at the next session. So thank you ever so much, everybody. Really good discussions today. See you soon.
Thanks.